I know it hurts. It hurts on most days to think. After 2 or 3 nights in Las Vegas, it really hurts to think. But that's what I want you to do. This is a reflective talk. The title of it is Sex, Racial, and Ethnic Disparities in the ED, but that's not what this talk should be about. What this talk should be about is us reflecting and using metacognition, understanding how our brains work, okay? Because if we don't understand how our brains work, we can't bring corrections to the way we think. Let's start with a simple example. How many of you wake up in the morning, say I have my 9 o'clock shift, I'm going to go to work and make sure everybody I see suffers in pain and that every procedure I do hurts like hell? How many of you think that? It's okay, you can admit it. I'm a pain expert, and the Marquis de Sade often comes into my mind. So how many think that? Nobody. So the question then comes, so why do you do it every day? Why do you allow your patients to suffer? Why do you do procedures to your patients that hurt? Because you don't wake up saying that's what you're going to do. And if you were the patient, you would never want to be hurt. Yet we hurt our patients every day. The sick and vulnerable, we do blood tests and don't think about the pain of the needles. We do reductions of fractures where the person's not really asleep, where we put NG tube down to patients, and yet if you ask patients, the worst procedure they endure in the emergency department is an NG tube. Because how many of your hospitals have a protocol that insists they get topical lidocaine in their nose 5 minutes before the procedure? Answer, none of you, which means, in theory, you don't care about the patient's discomfort. Because it never even enters your mind that you should do something about that discomfort. When you disimpact somebody with no medication, and we talked about those facial expressions we're both going to have, what do you think? Do you ever think, I should really be treating this patient's pain and they shouldn't be feeling any discomfort when I'm doing this? No, we just make the patient suffer. So the question is, since we don't wake up and consciously say, man, those buggers in my emergency department, I'm going to make them suffer, and we would never want to suffer ourselves, why do we allow ourselves to do that? And we could provide all the excuses in the world we want. Well, I'm in a rush, which means the patient's not your priority, you're the priority. I have other priorities, which is a lie. But the fact is, it's the way we think. Our subconscious way of thinking. In fact, when they looked at people who came into medical school and they asked them questions about pain, this is published in the Southern Medical Journal in 2003, and they asked people about what they thought about pain management. Day one of medical school. Based on their response, there was a 95% accuracy in predicting what specialty they would go into. No other questions could predict what specialty would use better than asking them how they would manage pain. So if I was to tell you, you're coming on to a shift, and I'm going to describe a case I had. You walk into a room, and there's a 27-year-old woman there who is whining and complaining about left chest pain that hurts when she breathes, and she's crying with her boyfriend, and why isn't someone take care of me, and why isn't it taking care of my pain, and I just hate being, and why I don't even have to come. That's her tone. Remarkably, her boyfriend goes out to get a coffee. She stops crying and says, well, I don't need to be here, I don't have any pain, I don't know why I'm here, in a very calm voice. Her boyfriend comes back in the room, this is terrible, I'm in so much pain, and why aren't you terrible? And you're going, oh my God. And every hair on the back of your neck is standing upright. And you're thinking, well, clearly there's nothing serious going on. Her vital signs are normal. Her boyfriend leaves again because they say we're going to discharge her, and as soon as he goes to get the car, she's pain-free. We send her home. She comes back 3 days later. Now she's got the exact same pain on the right side. And it's me seeing her again. Oh, God. I just want to slit my wrists. What did I do to deserve this? And sure enough, her mom's with her, but when she leaves the room, I'm fine, the tears stop, I just want to go home. Okay, like, how many would feel helpless at this point of view and just hate it, with their situation, right?
I would ask her, why are you doing this?
So, her brain is not working the way your brain does, and you are emotively affected by her actions. But if you do metacognition, you should be asking yourself, why are you being emotionally affected by her activities? Lidocaine gets injected, her pain's completely gone, she goes home. She comes back third time. Pain on the left side again, exactly where it was before. And I finally say, because it's me again. All right, I'm going to do a CT just to prove that you don't have anything. She has 3 major PEs in her chest. She has a protein C deficiency. Her mom comes to see her the next day in hospital. They're already talking about recouping costs of taxis and all these visits to the hospital, and why couldn't you pick this up? And her mom says, I was so mad I was yelling at the wall and I coughed up some blood. I've learned my lesson. I CT'd her. Her only symptom was I was yelling at the wall, I coughed up blood. She had a saddle embolism. She also had a protein C deficiency. So we all have ways that we think. We have biases that we've had since we were this big. We have cultural biases. We have social biases. We have personal biases. You can all name right now the personality of person that bothers you the most when you take care of them in the emergency department. For most of us in the room, it is the whining, clinging, dependent personality. Because it's the exact polar opposite of the personality required to work in the emergency department, an independent, active, decision-making person. Think of the person with a personality disorder, with immature mechanisms of social interaction. That's what makes up a personality disorder. None of you got training on how to interact with people with personality disorders. And this guy with a personality disorder comes in, and his other name for personality disorder is asshole. And within 2 minutes, you're getting really pissed off because he's pushed your buttons. And how many of you have met that patient? Right? You're really angry. How many of you have developed the metacognitive skills to say, wait a second, there's no reason for me to be angry. I don't know this person. I've done nothing wrong. Why should I be upset? I'm being manipulated. Cling, I'm being manipulated. I've developed a workaround so it doesn't bother me that I'm being manipulated, and I know how to deal with this person. How many of you have developed that skill? Right? None of us were taught that skill. So if we talk about these biases that we have, the inability to recognize our emotive state and the reasons behind it, we are going to treat our patients poorly. Because we don't understand how our brain's working and we haven't developed. I have multiple flags in my brain that automatically click on in certain situations. When the hairs on the back of my head stand up, it's, Jim, you can't stand this personality. You have to work around it. When I'm feeling angry or guilty, I have to work around it. When someone's angry at me, I have to remember, why are they angry at me? They don't know me. They've never met me outside for a coffee or talked to me or gotten to know me. They're not mad at me. They're mad at the situation or what I represent. But they're not mad at me, Jim Ducharme, because they don't know me. So why am I taking this personally? So a flag goes up and I change the way I think. How many of you have that set of flags to change your behavior? It should be automatic in all of us. That's metacognition. So since we don't have those flags, since we don't have the way to think around, because I will tell you, there's not a single person in this room that doesn't have buttons, right? I could piss every one of you off very easily because you all have buttons. As professionals, we have to ask, what have we done so that the buttons don't affect our care? When I was a resident in Los Angeles, yes, I was in La La Land, and I went to a La La Land course. Loving Your Patient, it was called. Only in LA. I also took a hypnosis course while I was in LA. It was great. So this guy came up on the stage and he had people hugging each other and going up and giving, I mean, it was the real deal. And I'm thinking at the start of this 2-hour thing, like, WTF, what am I doing here? I voluntarily signed up for this. What am I doing? And then he said a statement that has marked my entire career. No one asked you to love your patients. We're only asking that you care for them and about them. It's called empathy. You don't have to like them. You can even hate them, as long as you have empathy and you care about them. That's what we do. So it's okay to not like the person in front of you. But if you've developed your metacognitive skills so that you can work around that dislike so you can still be a caring provider, that's fine. Because they don't hate you or like you because they don't know you. So why are you hating or liking them? You don't know them any more than they know you, and you're seeing them vulnerable in stressful situations, so their personality is affected. Teach yourself or get taught the skills for metacognition. And if you do that, it's amazing how much stress disappears from your life in the emergency department. Because now these are all people that require empathy. It's not about you. It's not even about them as a person. It's about caring for the people you're treating. So, what have I done to overcome or neutralize all these barriers? There was work by Knox Todd, articles 1 and 2, that says we have biases. Of course we do, and we treat patients differently. But unlike all the newspapers around Knox Todd's article, it wasn't about race. Although black people and Hispanic people got less medication, in fact, the worst healthcare providers were Hispanic physicians taking care of Hispanic patients. They gave by far the worst pain management to their own cultural people. And yet it came out as discrimination against Hispanics. So why is that? Every one of you in your brain has an idea on how you should act when you're in pain. Every one of you does. There's a way to act. And where did you learn that? You didn't learn it at home. You learned it in medical school and residency training. Because I don't care what cultural background you come from, that's not your paradigm anymore. Your paradigm is you're a healthcare provider. Then secondly, you have a cultural background. And it's been shown in multiple studies that all of your negative biases that you came into medical school with, or physician assistant school or whatever, they got reinforced to make them worse. And any positive attitudes you had were just removed. That's what medical school does to you. That's what medical training does to you. And so it wasn't that white people were treating Hispanics badly, because the Hispanic doctors were treating Hispanic patients even worse. It was because they were all healthcare providers. Let me give you an example. A Hispanic patient comes in, with their pain. And what's your immediate reaction? They're such a drama queen. There's no way they're in that much pain. They're overacting, it's incredible. Right? We all think that. Then the stoic comes in with his broken femur, not saying a word, sweat dripping down his brow, and you ask him, how's your pain? It's not so bad. Well, he said his pain wasn't so bad, so I don't need to treat him. Because he's not acting the way he's supposed to act. And so that's what those studies really showed. That we believe you have to act a certain way, and if you don't act that way, we don't treat you very well. That's not race. That's poor cognitive function. Let me give you an example. I'm going to give you 3 people who all present with an open tibia fracture. Picture this in your mind. A world-class triathlete who's not going to go to the Olympics because he just broke his tibia. An 82-year-old demented nursing home patient who's screaming incoherently. And a heroin addict who broke his leg when he fell off his hog because it went around a corner too fast. Raise your hand honestly if you would treat those 3 people the same way. And the answer is, not a chance. There would be delays to be treating the elderly patient. You're not even sure if you give her analgesics because I don't know if she's in pain. You look at the addict with aspersion and you wouldn't want to treat him, and Lord knows we can't give him opioids, even though there's 20 studies that show that people with fractures like that, they have far less risk of abusing opioids if you give them opioids with a PCA pump in the emergency department, that not treating their pain leads them far faster to returning in the streets to addiction. But I've given you 3 patients, and you wouldn't treat them anywhere near the same. They have the exact same injury. They deserve the exact same empathy and the exact same care, and we treat at least one of them like shit. Probably 2 of them. That's biases in our brains that have us not thinking the right way. And we have to correct that. It's on us to correct that. Number 9 demonstrated that when physicians were asked how they would manage pain in hypothetical scenarios, there was never a racial discrepancy. The reason we focused on race is because it makes the news. Paula Tanabe, who's a PhD nurse from Northwestern, who's now moved to Duke, has done some great work on the barriers that we have in our brains. And what she looked at was visible pain versus invisible pain. So she uses as examples of invisible pain people with renal colic or vaso-occlusive crisis versus people with fractures that were visible. And she compared them. She demonstrated that people with invisible pain waited on average an hour longer to receive parenteral medications for the same level of pain as did those with visible pain. Because we don't believe the people who have invisible pain. Oh, you got a broken hip or a broken foot? Yeah, we'll get on you right away. You say you've got colic? Maybe. Can you pee for us? I want to see if there's blood. It's irrelevant that 30% of people with kidney stones don't have blood in their urine. It's irrelevant that the parasympathetic response to severe pain in your renal system prevents 30% of people with kidney stones from peeing. They literally can't get the bladder contraction because of the parasympathetic tone. We're not giving you something until you pee. Okay. She proved convincingly it's how we think. You don't have proof you're in pain because we don't have a thermometer we can stick up your butt and it registers a score of how much pain you really have. So therefore, because it's invisible pain, we don't treat you as well, we take longer, and we don't give you as much medication. Number 10 confirms that for the most part, healthcare providers are colorblind. In the survey of patients, their healthcare, patients were asked if they felt disrespect or that they received unfair treatment and correlate to the race of the provider. And the only thing they noticed, again, from the patient's point of view, that racial concordance with the provider increased the perception of being treated with disrespect amongst Hispanic patients. Black patients didn't feel that black or white doctors treated them any differently. The only group was, just like the Hispanic doctors didn't treat the Hispanic patients well, the Hispanic patients felt that Hispanic doctors didn't take good care of them, because funny, they didn't. What are some other documented ethnicity-based disparities unrelated to analgesia in the treatment of ED patients? There's a bunch of articles talking about testing. And although it's meant to show bias towards visible minorities, there are some of these things I'd rather be in the visible minority. Number 11, you were less likely to have a CT of your head when presenting with a headache if you were black. Note that all the white people, Caucasians who got extra CTs, none of them had any abnormalities. So the question is, are we responding to unvocalized or vocalized expectations, and that certain people with greater health education are asking for more tests, so we feel we should order more tests? And the people with less education who aren't insistent, we're more likely to go with what we think is reasonable. So it's not just about race. Number 13, looking at abdominal CT for blunt torso trauma, an absolute difference of 19% between black and white children. But there was no socioeconomic data in this study, because then we come to number, let's see, where is it? That a lot of the people who get poor care have poor health education. They don't know what they're asking about. They don't know what they're talking about. So we tend to under-investigate people, not because of color or ethnicity, but because of health education level. And because of socioeconomic factors like, I'm not sure they can afford the test. They don't seem to be pushing for certain tests because they haven't gone on the internet. And there was a recent article about people looking up stuff on Google before they come to the hospital, and it confirmed what I've known for years. The worst thing you can do is go to Google before you come to the hospital. Because all you do is see the bad words. You have no context, you have no filter, so you assume the worst based on what you read. Remember when you were a little tiny second-year student in your training? Nurse practitioner, physician assistant, and someone said to you, or they should have said to you, a doctor who treats himself has a fool for a patient and an idiot for a provider. Because there's no objectivity, there's no filtering, there's no context possible. So a person who hasn't had all that medical training goes on to Google. They're even worse. And so all they see are the scary terms, and then anything you look up, cancer is mentioned somewhere. I had a lady come in a few weeks ago because of palpitations, and she said, I've got beriberi. I said, wow, I need to report this because there hasn't been a case of beriberi reported in North America in 150 years. You'd be a first. She says, are you making fun of me? I said, no, but if you do have beriberi, I'm going to become famous. So we have to understand we are negatively influenced, all of us, by the person who comes in and says, I looked it up on the internet and I think I've got this. How many think they're not negatively influenced? It's a bias. It's metacognition to recognize that you're biased by that. The person who has very limited health education doesn't do that. So they don't come in insisting that they have this or this test or that test. So we tend to do more tests, less tests on them. This is unvocalized or vocalized expectations and us responding to them. What about the impact of gender and sexual preference on ED care? Remarkably, number 16, 1/3 of patients who responded to a survey said they would change providers if they discovered their provider was gay or lesbian. 1/4 felt they should be told when they come in the room what the sexual orientation of their physician, of their provider is, before the interview starts. You're shaking your heads. You can't shake your heads This is what our patients think. We have to be aware of that and deal with that. We have to be aware of, just like we don't have our brains working the way we should, and we don't have the metacognition to change the way we think, our patients have it even less so. And that they come in with biases just like we do. They think they need a test, and you're telling them no, they can't have the test. They get angry because in their brain, they think that test is necessary. How do we get them to understand that it's not necessary? Well, the first question I have to ask you was, how do you get to understand your brain better? And if you can't figure that out, then how the heck are you going to change the brains of the people in front of you? Number 15, back to pain. Women with abdominal pain receive less opiates and wait longer for analgesics than their male counterparts. So I wrote down, so let me see. Let's see who's discriminated against in all the research. Women, children below age 6, over the age of 70, altered cognitive function, altered mental status, racial minorities, perceived drug seekers. That doesn't leave a lot of patients. Again, if you don't fit the paradigm of how we believe someone should act, we treat them poorly. We just do, unless we use metacognition and recognize our own barriers and ways of thinking. Number 17, qualitative study. And this is a very reflective study of my own personal experience early on in my practice. Up to a third of transgender patients delay or avoid seeking health care because of fears or past experience of discrimination, harassment, or denial of services. How many believe that's true? Absolutely it's true. Let me tell you, I've been in practice for a long time. When I was first starting out in practice and homosexuality wasn't as accepted and as open as it was, I was treating gay patients in my emergency department in Montreal, and then I moved to Los Angeles to my residency, and I kept getting hit on. I'm as straight as can be, and I kept getting all these great compliments. And I told them they were fantastic compliments. These gay guys kept asking me out on dates. And I finally said to a guy, I'd had about 20 guys ask me out on dates in a period of 6 months. So I finally said to a gay guy, I said, you know, I'm really flattered you guys find me so good looking. But I'm as straight as can be. Why is it you guys keep asking me out on dates? And you know what the answer was in 1981? You treat us like normal people, so we think you must be gay.
Wow.
Is that a condemning statement of our profession or what? That means the vast majority of doctors treating gay patients treated them like crap. And in 2018, the article number 17 says that's exactly what transgender people feel today. We treat them like crap. I had a guy on my shift on Tuesday who was going through the process. He was still using the pronoun he, which surprised me because he already had breasts. So he was going through the process, and as far as I could see, he was actively transitioning. And yet, I respected him and called him him, and what does he want? Because that's what he preferred. I even asked him. I said, since you're actively transitioning, may I ask why you're not yet calling yourself she? And he said, because I haven't yet started my hormonal therapy. I've had my implants, but I haven't started my hormonal therapy, so I still call myself he because that's what I've been to date. And he said to me, and you're the first person who's ever been willing to ask me openly. People, our brains don't work the way they should. It's not our fault. It's not because we're bad. It's because we haven't learned how to train them to think better. Number 18, in methodology, they felt that socioeconomic status and race impacted on the outpatient prescription of opioids. Are there issues or concerns related to the treatment of ED patients based on religion? Absolutely. We have 120 different languages spoken in our hospital. It's a cultural experience like no other. But when I deal with Islamic women, some of whom request a female physician, many of whom refuse to get undressed because they're certainly not going to let me, a male, see their body. Because when I've been in Riyadh or Kuwait or Qatar, because I've been in a lot of Middle East countries, in the emergency department, it's very simple. The women go one way, the men go another way, and women are never treated by male physicians, ever. So Islamic people, when they come to Canada, especially from the Middle East, the women are taken aback by the fact they're being seen by a male physician, and they react. So we react, unless we have cultural understanding.
What do you do?
I ask them. I go in.
And they continue to say no.
I go in and explain the situation. And then what I do, just because I'm in Toronto, so I have lots of hospital options, I will call the nearest hospital and say, do you have a female physician working? And because the hospital that's 8 miles away from me, which is the nearest one, we see 150,000 people a year. They see 100,000 a year. Between the two of us, I think lightning has a better chance of striking me than us not having a female physician working between the two of us. There is 45% of the physicians in my group are female. And we have 18 physicians that working a day. So us not having a female physician works. It just almost never. But if we don't, then we call the hospital that's nearest. Now, if you're in a small community hospital, like when I work in my small community hospital 150 kilometers outside Toronto, I'm the only doctor. And I explain to them, I'm the only physician. I'm willing to examine you through your clothes. Is that acceptable? And we have a discussion, and we do what we can. But I'm certainly not going to broach or breach what they believe and respect completely.
How does that affect, let's say, medical legal issues?
You document very clearly. This is the agreement that came with the patient. The patient, for religious reasons, refused this and this. We had a discussion. This was a compromise we agreed to. The patient accepted this would be a compromise. You just document it. But because I tell you, if you try to force what you need to do on that patient, you're dead in the water.
What if they're altered for whatever reason?
You do what you can. It's like you have a Jehovah's Witness, right? You do what you can. All right, to finish up. Number 21, the belief that poor people sue more than rich people is just not true. I don't know where that belief came from. I worked at LA County Hospital for 3 years. I work in a socioeconomically challenged area of Toronto. They are grateful 99% of the time that you're taking care of them. Recognizing that and one of the things that they find very important is I consistently ask, can you afford the medications I'm going to prescribe for you? Because even though the medications are less expensive in Canada, inhaled steroids are expensive. And it's the basis for the treatment of asthma. So our policy, because we're in a hospital that has a lot of poor people, you come in for asthma, we treat you with a spacer and MDIs. One, because it's the best way to do it, but two, because they always go home with the spacer and with the MDIs that we used. They always get them free of charge. Because we've been shown, because they can't afford to buy some of their medications or the spacer, it costs the system far more money with bounce backs than if we give them the stuff. And so we give them the stuff. So you never know who might sue you. Treat everybody the same way. You don't have to love your patients. You have to care about them.
Just going back to the previous discussion on religious,
So don't forget, remember what we said at the start, it's not about you.
I know.
It's empathy. Two, if the person is acting out and being abusive, that's a felony. It's called assault. And you don't have to endure that. Verbal is still a felony. Battery is physical. Verbal is assault. You don't have to tolerate that. And if there's verbal abuse, you should have signs, first of all, in your emergency department that say, we don't tolerate, zero tolerance for verbal abuse. That should be everywhere in your emergency department. And two, there should be a simple rule. Jim's World, you can't swear and have me take care of you. Whereupon most of the people who have personality disorders, i.e. assholes, they swear again. I said, well, then I can't take care of you. I'm calling security. That's not me being intolerant. That's not me being emotional. I have policies that say this is unacceptable. I don't have to submit to felonious behavior during my shift to provide care to patients.
Do you feel like your admin backs have you escorted out by security?
And that's perfectly appropriate. That's not, but as long as you're empathetic and making sure you're not missing something important, but also understanding that they don't have the right to abuse you.
But that guy was rewarded by a different.
No, he wasn't. He wasn't rewarded. His behavior was ignored, which is bad cognitive function of the physician. He wasn't rewarded. It was ignored. Remember again, because I think, who's up next? Okay, last thing I'm going to say, in all of this, bad behavior from patients, from your peers, from your consultants, you deserve what you accept. Dr. So-and-so, the cardiologist, is an asshole every time it comes down, and you say, well, that's just Dr. So-and-so. Good for you. You deserve it because you accept it. So think about all this, and then go back and look how you treat your patients and how you look at gender issues and how you look at racial issues, how you deal with personalities, and figure out amongst yourselves how you're going to develop the metacognitive skills to properly approach your patients with empathetic care in a consistent fashion. So you can pick your pens back up, and Raman's going to talk to you about the next topic.